If it is, at least you'll have something current from this year and not have to pull from last year's material. I hope your exam went well this morning. I hope the study guide was helpful and sufficient. I haven't looked at your grades yet, to be honest, but I will soon. And my hope and my prayer is that you all did very well. The study guide was very comprehensive, and I really feel very strongly that you need to learn what we see as important for you to know clinically and what is important for you to know for the pants. And no matter how you learn those things, they're useful to you. So if the test seemed easy, then great. If it seemed difficult, then we probably need to talk, because it was a pretty good outline of what you should have expected to see on the exam. So let's move right on into infertility. Before you can talk to patients about infertility, it's important that you talk to them about normal fertility. So a phrase or a term that you may run across is fecundability, and this is just the probability of achieving a pregnancy in a single menstrual cycle. So the fecundability of patients decreases as the number of consecutive months without achieving pregnancy increases. So the longer a patient goes without becoming pregnant, the less likely she is to become pregnant. One great statistic to tell patients who are young, who are healthy, who don't have any other barriers to fertility, is that 85% of these couples will become pregnant within 12 months of unprotected intercourse. I find this, again, very comforting for patients. And waiting that 12 months can be brutal for some people, but it is also comforting information. So in the normal fertile cycle, the fertile interval extends from about 5 days prior to ovulation to the day of ovulation. This will become important as we look at the different ways of predicting ovulation, because many of them are, or some of them are not useful until you have charted information over the course of a couple of cycles, and they're also only useful for patients who have regular cycles. It's difficult to determine from measuring, for example, basal body temperature one cycle to tell when the patient is ovulating. So again, we need a patient who has regular cycles and is willing to go to the trouble of measuring basal body temperature throughout those cycles. We'll talk about what that is on the next slide. The highest probability of conception will occur when intercourse takes place 1 to 2 days prior to ovulation and then on the day of ovulation. So it's hard for patients who aren't willing to measure their fertile period to tell them when to have intercourse. Generally speaking, it's good advice to tell a patient that having intercourse every 1 to 2 days, beginning soon after the cessation of menses, should suffice. And every 1 to 2 days means regular intercourse, so 2 to 3 times a week. And there's really not much evidence that having sex more frequently than that increases your chance of becoming pregnant. You really should be able to capture that fertile period if you tell your patients to have intercourse 2 to 3 times a week, beginning soon after the cessation of menses. A lot of patients will come to you with some interesting ideas about what will increase their likelihood of getting pregnant. So patients will tell you that a missionary-style pregnancy, or that the traditional male on bottom, they're more likely to get pregnant. Or if a female has an orgasm because of the contractions in the uterus propelling the sperm up into the cervix and into the uterus, makes them more likely to become pregnant. Neither of these things are true. You've probably also seen in the movies a lot of times women who are trying to get pregnant will flip over on their backs and throw their legs in the air and put a pillow under their hips to elevate their hips, again, all in an effort to get that sperm heading in the direction that it's supposed to be going if conception is desired. So contralaterally, if that's the right word, um, using these things as ways to avoid pregnancy, also not effective. Interesting to note that there are some lubricants that inhibit sperm motility in vitro. These are the ones that you see most commonly on the shelf, KY jelly and Astroglide. There's really no evidence to suggest that they impair fertility in human subjects or in human trials, but in vitro they do slow down sperm motility. So if I have a patient who's trying to get pregnant, I do guide them toward a lubricant that is a little more fertile friendly. It's not quite as thick, it's not quite as sticky as the KY and the Astroglide. It's called Pre-Seed. I'm going to show you a real quick picture of it. You can buy it at CVS, Walgreens, whatever your favorite local drugstore is. It's a little more expensive than the regular lubricants, but again, patients who are coming to you and trying to become pregnant really are desperate in a lot of ways, and they will do what it takes to become pregnant. So the extra cost of that lubrication may be worth it to these patients. So probability of becoming pregnant following intercourse, as long as it takes place on the most fertile days of the cycle, you can read here. And these are for age-matched male controls. So we go from 50% chance of becoming pregnancy in any given cycle in which the female has sex on the most fertile days, dropping to 30% chance on any given cycle in which the patient has sex on the most fertile days. Again, age-matched controls are important. It does affect the numbers slightly if the female is younger, the male is older, and vice versa. I don't want you to memorize these numbers. I just want you to understand that the probability of pregnancy does drop as patients age. We have this push in our Western society to establish career first. I think that a lot of women feel that pressure without showing my gender bias, although I guess I just did. But a lot of women do feel that pressure to kind of climb the corporate ladder before they start a family, and it's important to keep that in mind as you're counseling your patients. If you have patients who are 27, or excuse me, in their late 30s, that they're really, kind of rolling the dice on how easy it's going to be to become pregnant, and the longer they wait, the more likely they're going to have to use assisted reproductive therapy in order to become pregnant. So how do we predict ovulation? And we can use all of these methods to predict ovulation in order to become pregnant, or to predict ovulation in order to avoid pregnancy. So one of the ways is a basal body temperature. This is a special thermometer, a basal body thermometer that's used. It's very special because it's a little more expensive than the other thermometers, and it measures to 1/100th of a degree rather than 1/10th of a degree. I don't know that it's absolutely necessary to have the special basal body thermometer, but they sell. So, and there are cases in which those minute changes in the 100th place of the temperature may be important. So you can advise a basal body thermometer temperature. They're not that expensive. They're just a little more expensive than the regular thermometers, although less expensive than those temporal scans and the ear thermometers and all the wacky stuff they have out now to make temperature taking more comfortable for children. Temperature drops during menses and then rises 2 days after the LH surge. Now, just reading that statement, you can see why it would be difficult to make any prediction about ovulation from one cycle unless you have a perfect chart. I'll show you a couple perfect charts in the next slide. But because you want to have sex the 5 days before LH, or before ovulation, remember LH is what triggers ovulation, and then you want to have sex on the day of ovulation, that LH surge is going to take, a day or two to stimulate the actual release of the egg, but it's difficult. It's difficult to tell with that rise, and it's rising 2 days after the LH surge, so there's a high likelihood that you would miss ovulation from one chart. Typically, the oocyte is going to be released a day before the first temperature ovulation. So that's another thing to keep in mind. So when we're looking at these beautiful, lovely, perfect charts, we can, sorry, my computer is doing weird things. We can see that the temperature is low in the first phase of the cycle. In the follicular phase, it increases in the luteal phase. And you can also see here that we get a drop in temperature, and like we saw on our previous slide, that oocyte is released a day before the first temperature elevation. So if you have a woman who's really riding high during that follicular phase and has a dramatic drop, you can assume that after that drop in temperature, that ovulation is going to occur before the next elevation in temperature. They aren't all this clear, so if you look at this chart over here, you could mistake on day 11 a drop in temperature guiding you or telling you that you are ovulating, when really it's not here until day 17, because that's when the temperature goes back up over this baseline temperature. So that's what you're really looking for. You're looking for that elevation in temperature that continues up and up and up and up and up over that baseline. So difficult to tell. Notice too on these, excuse me, that was day 15, not day 17. I was looking at the date up here. Look down here too at the cervical mucus. So we're looking at the different types of cervical mucus. Typically your charts will give you a legend that will tell you what the cervical mucus is. This E is for egg white cervical mucus, which is the thick mucus that is associated with ovulation. Patients may also do ovulation predictor kits, starting around day 10 or 11. They can be a little expensive, and so that will vary from patient to patient. But when the ovulation predictor kit becomes positive, then that's an indication that you want to have intercourse if you want to have sex, and avoid it if you don't want to have sex. And then looking down here, honestly not sure what this acronym is. It might show up on one of our other charts, but I'm not sure what that one is. So the ovulation predictor kits measure the LH surge in the urine, and remember that ovulation occurs 24 to 48 hours after urinary evidence of LH. So there are a couple things to keep in mind here. These are the easy ones. This little smiley face that you get once you have once ovulation occurs. And the other are the ones that look more like pregnancy tests. Really important to note, in a pregnancy test, any faint second line implies pregnancy. So any second line at all implies pregnancy, unless there are some crazy kits out now that will give you 2 lines and then a plus symbol somewhere else on the stick. And I don't know how many heart attacks that has caused, but I'm sure quite a few. So make sure that you have your patients read their their tests carefully. These are special tests, though. These are not pregnancy tests. They are LH prediction tests, so make sure the patient's picking up ovulation tests and not pregnancy tests. But you want to wait until those two lines are the same color or the same density of color. So even on day 16 here, if you look at it closely, this line on the left-hand side is just a little lighter than the line on the right, and so really we're looking at post-menses day 17 that this patient is ovulating. So another method, again, to either enhance or avoid fertility. So typically in a patient who has a 27 to 29 day cycle, this can be useful. Days 1 through 7 of a cycle are considered infertile. Days 8 through 19 are considered fertile and unsafe for intercourse or unsafe for unprotected intercourse. So sometimes during this period of time, patients will use condoms. And then day 20 through the end of the cycle are also considered infertile. When used to avoid pregnancy, this standard days method is 95% effective with perfect use, but typically patients, again, just don't have the discipline necessarily to track the days of their cycle, and so the typical use efficacy is 88%. Now, as we add in the basal body temperature and the ovulation prediction kits, then this becomes a little more efficacious. And then the last thing we can add into this is looking at cervical mucus. So typically day 1 through 5 menstruation occurs, day 6 through 9 the vagina is dry with little to no mucus. Days 10 and 12 we start to get this sticky, thick mucus that gradually becomes less thick and more white. And then typically days 13 to 15 that mucus becomes thin, slippery, stretchy. If you stretch it between your fingers, you'll actually get a string of fluid that looks like an egg white that is stretching out. And this is going to be the most fertile phase. I don't like telling patients just to avoid sex on days 13 through 15. Really prefer this 8 to 19 days of encouraging protected intercourse for patients who do not wish to become pregnant. Day 16 through 21, the mucus becomes sticky and thick again, and this is not considered fertile mucus. This day 13 through 15, again, is the fertile mucus. And then 22 to 28, the vagina becomes dry and menstruation occurs again. So combining all these methods together, you can get a pretty good handle on your fertility. It's a lovely way to get to know your body if you have the time, which I'm sure all of you do right now, have the time to lay in bed for 5 minutes and take your temperature first thing in the morning. But pardon me. I have found as you age and as you start to really want to move towards natural methods, that this can be a way to move toward a natural method. There are lots of people who like to avoid hormones for one reason or another. I happen to be one of those people, and so I'm diligent about these things, and it has worked. Believe it or not, all 4 of my children are intentional. That's not exactly true, but that's a story for another day. Anyway, so let's move on from observing cervical mucus. So moving on to infertility, this is going to be the inability to conceive despite frequent coitus. Women under age 35 are evaluated after 12 months of unsuccessful attempts to conceive, and then 35 and older, we evaluate them sooner just because their fecundability is dropping faster. Infertility can be a real problem for patients emotionally and physically as they go through some of the treatments for infertility, but very frustrating. Women will feel inadequate or like their body is failing them. And so I always advise some mental health counseling along with this, along with these patients who are struggling with infertility. I like to show this slide because I like to let everyone know that there's a whole big part of this that's unexplained, unfortunately. And then there's this other big part that's not a female problem, and this can help some patients. So sperm problems account for around 21% of infertility issues. And then there are other problems here: ovulatory failure, so we've talked at length about that; tubal damage, which can occur again from the PID, and endometriosis, cervical mucus, and coital problems. People are not having sex at the right time, maybe not even having sex in the right way. So it's worth exploring, how your patients are having intercourse. Maybe all their life they have been taught to withdraw before they ejaculate, and it's time now to educate the patient who wants to become pregnant that it's important, while you can get pregnant with the withdrawal method, again, Russian roulette, it's important, that couples are having sex in the right way. Sometimes it's an uncomfortable conversation to have, but couples who are dealing with infertility will talk about anything. So make sure you have those tough discussions. So what do we test during an infertility evaluation? And I'm giving you really the very beginnings of the tests, because this, as a PA, is what you need to know. And I do want you to know these things. More the initial evaluation than the further evaluation category. So as you're studying for your exam, focus on the initial evaluations. If there's anything in here that I feel like you need to know in terms of further evaluation for your exam, I will tell you. And I feel like if you end up in this field, you're going to learn this, and there's just no need to bombard you with information that's not going to be useful to you now, not going to be useful to you on rotations, and is certainly not going to be useful to you on my exam, and probably not on the pants either. So our first evaluation is of the female. We are looking for ovulation, and we've talked about all these ways that we're looking for ovulation. So history and physical, basal body temperature charting, ovulation prediction kits. Those things are going to be very, very important. The uterus requires an ultrasound, and one thing I do want you to know about this ultrasound is that it's important that we make sure that this is moving down to fallopian tubes, that we do the hysterosalpingography to make sure that the tubes are patent. And I'll show you a couple pictures of that. So the hysterosalpingogram is very important. For males, we will do a semen analysis. What we're looking for here is morphology of the semen. We're looking for speed. We're looking for numbers, making sure that all those things are in place and within normal range. So ovulatory dysfunction, I feel like we've beat this horse to death, but there are a few things that you need to think of when you're thinking of ovulation or anovulation. PCOS, again, beaten to death. Thyroid disorders, so we may want to check TSH, and hyperprolactinemia, so looking at the prolactin level may also be helpful. Anatomic factors, when we're doing our ultrasound, we're looking for fibroids, polyps, we're looking, sometimes we're able to visualize intrauterine adhesions. A lot of times to visualize those, we're going to have to go back to our saline-infused sonography. And if you remember, that allows us to open up the uterus, take a look inside and see what's going on, and maybe see those adhesions. And remember, the adhesions are caused often by pelvic inflammatory disease that is causing scarring in the fallopian tube. We also need to look at congenital abnormalities for the fallopian tubes themselves. And going back real quick to the intrauterine adhesions, don't forget about Asherman syndrome. Can also cause intrauterine adhesions, and dilation and curettage. History of dilation and curettage can also cause adhesions. Typically, they're not as severe as Asherman syndrome, and we're able to take care of those, and they don't cause an outflow obstruction, but we need to look at those. So fallopian tubes, PID, is the primary cause of infertility. That's tubal factor infertility. So again, those infections will cause scarring within the fallopian tubes, and we can evaluate this by doing the hysterosalpingogram. So looking here as a normal hysterosalpingogram, we've gone intracervical. We're doing this live fluoroscopy. The dye is spilling out. You can see into both fallopian tubes and then spilling out into the peritoneal cavity. So we know that those fallopian tubes are patent. On the top here, we have dilated fallopian tubes with distal obstruction. So the dye here is getting trapped, and it's just hanging out in the fallopian tube. So something's going on here to keep the dye from not coming through. And then here we have bilateral proximal obstruction. So the dye is not even making it all the way into the fallopian tube at all. Male factor infertility, we talked about this briefly. We're looking at quantity and quality of seminal fluid, the number of sperm or the sperm concentration, and then the sperm mobility and morphology. As you can see here, we have a normal sperm count and then a low sperm count. No reason for you to know numbers at this point. Also important to notice that normal sperm have a normal-sized head and a normal tail. This is a biheaded sperm. This is a sperm with two tails. These sperm obviously are abnormally shaped. So treatment for ovarian stimulation, we're going to use Clomid. We typically administer this from day 3 to 5 of the cycle for 5 days at a dose of 50 milligrams to 150 milligrams. We'll also give metformin to patients daily for patients with PCOS. While metformin has not, there's been some anecdotal evidence for a while now that metformin increases fertility. The information kind of goes back and forth on that, but it's not a harmful medication. A lot of these patients, again, have metabolic syndrome, and so metformin is a reasonable choice to give to patients with PCOS and infertility in the hopes that it may do something to enhance the the treatment of the PCOS in general, which can then enhance the excuse me for just a second. Okay, I apologize for that. Intrauterine insemination, there's lots of artificial reproductive therapy. You may see it abbreviated as ART out there. And intrauterine insemination is actually the male's, the partner's ejaculated semen is inserted into the vagina via a catheter. Now this is if the male's semen is sufficient. Sometimes if we have poor numbers, we can combine samples. But very, very often we're able to get a biological father and a biological mother pregnant with intrauterine insemination. Any fertility procedure that involves manipulation of the gametes, the zygotes, or the embryos to achieve contraception we refer to as assisted reproductive technology. 99% of ART procedures in the U.S. are in vitro fertilization. So in vitro fertilization, the ovary is stimulated to produce multiple follicles. The oocytes are retrieved from the ovaries, fertilized in vitro in the lab. The embryo is incubated in the lab and then transferred to the uterus through the cervix. Chances of conception are high as 40 to 50%, and typically we will insert and transfer more than one embryo, and so there's a higher chance of multiple gestations within that embryo. This kind of jumps into a theological, ethical debate for a lot of patients. Are we playing God here and trying to use these different techniques to do something that the body is not wanting to do on its own? That's something that every patient has to be counseled on, and every patient has to decide for him or herself. I like to tell a story of being a nanny in college, and the two children that I was a nanny for, their mother had Turner syndrome, and they were very religious and just beautiful people, and their children actually ended up being the flower children in my wedding. But they struggled mightily with manipulating the embryos that were fertilized outside of the body, and finally came to a decision to test them and to not implant any embryos that carried the gene for Turner syndrome. And it's a decision that they thought about, they prayed about, and really never looked back because it was well thought out. But these are things that patients need to be counseled about. Probably not something you'll do as a PA unless you end up in vitro fertilization or in assisted reproductive technology. But again, always thinking about the implications that any of these procedures, that any of these things have on the patients that you're treating. So you can see here, we're getting egg production stimulated by hormone therapy. Eggs are retrieved from the ovary. Eggs and sperm are combined to allow for fertilization after the sperm sample is provided, and then we have the fertilized egg introduced into the uterus. So moving a little further into this, there are many other things that can happen. And if the woman who desires pregnancy is not able to carry a pregnancy to term, or is not for one reason or another able to achieve implantation, surrogates can be used. So there's a whole big field, and again requires a lot of counseling, a lot of patience, a lot of interest in your patients. So in class work, I want you to have some idea of fertility awareness. And so what I'd like for you to do is take the chart that's posted under lecture 6, and I want you to fill it out just fictitiously. noting what you would expect to see in typical temperature changes before and after menses. Notice what you would expect, or note what temperature changes you would expect to see before the LH surge, before ovulation. And then at the bottom, there's a place where you can notice what you would expect to see in terms of cervical mucus. And then make a note on your chart where or when you think the patient should have intercourse. You can email this to me. I would actually love to see the charts that you come up with, because I've been so impressed with your group work so far. So I'm going to go ahead and put on here that I want you to email to me by next Friday. And let's see, the date next Friday is going to be March 4th. I don't know what you have going on this week, so I want to give you plenty of time. And let's do an 8 a.m. so I have them before class starts, and I might be able to show them to you. If you find a better chart online that you would prefer to use, feel free. I have no problem with that. And I believe that's all we have to talk about with regards to infertility. Thanks for your attention. Thanks for your patience as I'm moving through a difficult time. It's greatly appreciated, and I will try very hard to keep up with emails. If for some reason you are desperate for information and I am not getting to emails, feel free to call me. This is my personal cell. I hate not being available for patients, or for students and patients, but feel free to call me should you need anything. I will answer if I can, and if I can't, I'll get back to you. So thanks again, and I will be up with the next recording in just a few minutes.